Thanks, Olivia. Hi, everybody. So today I would like to share with you some of the steps that many programs used when they initiate a large-scale investigation. Once again, it is not our intention at any time during these webinars to suggest supplanting your local standard of practices. So I thought maybe we'd start with the infectious period exercises that I believe everyone received last week or recently. It seemed that Sean and Helen would like me to at least review at least one of the scenarios and maybe go over some of the responses. Is that what you'd like me to do, Sean and Helen? Well, okay, I'll do it.
Thank you.
I'm sorry, go ahead.
Yeah, go ahead. That sounds good.
Okay, thanks. So I'll do scenario number one. I'll just summarize the scenario and we'll just walk through what we feel are some of the appropriate responses. So scenario number one, this is a gentleman who on December 4th was hospitalized, had a cough, was placed in airborne isolation on that day. On the same day, December 4th, sputums were collected, were smear positive, cultures pending, x-rays taken on the same day, December 4th, were read as abnormal with cavitary disease. I'm sorry, everybody, I'm just trying to advance the slide. It's not advancing. Oh, okay, sorry about that. Olivia is so professional, I forgot to do this. Cavitary disease, the diagnosis came in, started appropriate for drug therapy on December 5th. The patient states he started coughing around November 6th, with symptoms resolving a few weeks, about a month later. 6 weeks later. 3 consecutive negative smears were collected or not reported until February 10th. So the question in the exercise is the date of the first symptom onset consistent with TB, whichever is longer. And so based on the scenario, the first abnormal finding consistent with TB was the cough. And so we would put in that column, we would put in I guess it was November 6th, the patient said he started to cough. Because we're going back, yeah, we're going back. He started December 4th. Wait a second now, it's November 6th. Yes, I'm sorry, the patient said November 6th started to cough. Sorry about that. So that was the first symptom onset consistent with TB. So the question is, when do we start the infectious period? Well, based on CDC recommendations, we go back 3 months prior to the onset of the cough. That would bring us to August 6th. I always round it off the first of the month, so because these infectious periods are so unscientific, they're just estimates, so I always round it off the first of the month. So for purposes of this scenario, August 6th or August 1st. And the date of the end infectious period for contact investigation purposes, we would use December 4th because that's when the patient was placed in airborne isolation and community exposure was broken. So for purpose of contact investigation, we would say when we're interviewing the patient, we would say from August 1st until December 4th, let's talk about your life, who you live with, who you socialize, who you work. We want to identify contacts during that time period. However, the biological end, according to CDC, is when you have 3 negative smears, and that would be February 10th. But we're not going to wait until February 10th to interview the patient. So on December 4th or 5th, when we see the patient, we can say that community exposure was broken on the 4th. We can go backwards until August 1st, and that's our infectious period for identifying contacts. Any questions about that scenario? That's a typical scenario. If your program hospitalizes patients, it's very easy to figure out the end date for contact investigation purposes when someone's definitely put in airborne isolation. But sometimes patients are not. Sometimes patients are sent home and they're not in airborne isolation. So we could look at scenario number 3. We can just take a minute to do that because that's a little different. So this is a woman who saw a doctor on May 9th. During that visit, she had abnormal film, collected the sputums, positive smear culture was pending. She was diagnosed, I guess, a day or so later with suspected pulmonary TB, started inappropriate for drugs, and was put in home isolation. She denies, patient denies ever having a cough or any other symptoms. 3 consecutive induced sputum smears were negative on June 1st. So date of symptom onset or first finding consistent with TB, whichever is longer, there was no cough, but there was an abnormal film. and we can mark that in as May 19th would be the first abnormal finding. So we count back 3 months prior to that, and that brings us to February 19th, or again, I rounded off to February 1st. So that would be the date of the beginning infectious period, February 1st. Now, for this patient who was never put in airborne isolation, we have a couple of choices. We could say that she was put in home isolation. Now, we don't know if she's living alone or living with other people based on the scenario, but we could say May 20th, she was put in home isolation, or we could go back to the old days and count 14 days of treatment, which would be June 3rd, 14 days after treatment, we can consider her possibly non-infectious. The biological end, of course, is easy because that would be 3 negative smears, which was collected on June 21st. So someone who's not hospitalized does present problems in terms of maybe continuing exposure in a household if they're living with other people. So that is something that's problematic and can be discussed with management team in your states as to when really we can call the infectious period over for contact investigation purposes. So any questions about these two scenarios? The first one was typical, hospitalized, airborne isolation. The second one is not so typical, but does happen. And so that does cause concerns about potential transmission ongoing in the community, especially if the patient doesn't stay isolated. So any questions about those two scenarios before I move on? Okay. Okay, so, and we can have questions later on if you like, by the way. So, so last month during our talk about contact investigations, I did touch a little bit about large-scale investigations. So some of the slides are going to be repeated here, not many, just a couple. Decided to leave them in for emphasis purposes. So a definition of a large-scale investigation is an environment where a number of people meet or gather and share the same space, airspace, for either a limited or extended period of time. So these are some of the more common Congress setting sites that I showed you last month, actually. I'm sure, hopefully they look familiar to the group I'm talking to. These are very common throughout the United States. I know for us here, we do many high schools and college universities. Houses of worship is a red flag for me, I'm sure for you as well. It doesn't necessarily mean it's a cathedral, temple. It could be a storefront where there's maybe 800 square feet and 50 or 100 people packed in on a Sunday, or an evening Bible class. So that's a red flag if someone's infectious in a storefront church. Elder care facilities, I've done numerous investigations in assisted living facilities and nursing homes. Social recreational, my favorite was a tavern investigation I did here in Newark. That was, there was a shooting in the tavern while we were there. It was really quite a memorable investigation. But anyway, so these are more common sites. Again, across the country, I believe that this is very usual for TB control programs. So the first thing we need to do in our programs is decide whether or not an investigation at a large-scale setting is really recommended. That depends on your standard of practice. So we need to assess whether or not to initiate an investigation. So information collected from the medical record review and the TB contact investigation interview is necessary to determine the level of infectiousness of the patient. Obviously, we look at bacteriology and pathology results, radiographic findings, and symptom history. So for bacteriology, we're looking for, obviously, if it's a sputum or bronchial wash, we're looking for how many AFB were there. Was it 4+? Was it 1+? We're looking at radiographic findings to determine whether there's cavitary disease or not. And of course, we're looking for a cough. Cough is, as you know, the main way the bacteria is spread from the lungs. Regarding infectious period, this is very important TB control. We talked about it a lot last month. In accordance with CDC guidelines, the healthcare worker estimates the period of time that the index case was probably determined to be infectious. Again, the infectious period is not a scientific, it's not a precise calculation, it is an estimation. But it does allow us to focus questions to the patient for the purpose of identifying high and low risk contacts at all exposure sites. So, the CDC recommends if sufficient program resources are available, the on-site assessment of the congregate setting should be initiated. if the index case is diagnosed with suspected confirmed pulmonary laryngeal or pleural TB and presents with smear-positive respiratory specimens and or cavitary disease with cough or laryngitis. Now, here in New Jersey, we do not investigate pleural TB patients in terms of contact investigation or large-scale settings unless there's a pulmonary involvement as well. I'm not sure what other programs do. Some programs do investigate pleural TB. New Jersey used to many years ago, but we stopped. But again, if there's pulmonary involvement, then we would proceed with an investigation. So I guess a question to ask the group is, in Michigan, do you investigate pleural TB in terms of household contacts and or if it's a workplace or school investigation? Do you do that in Michigan?
Yeah, this is Shauna. Can you guys hear me?
Yes.
Yeah, so we encourage investigating these if resources allow.
Yeah.
We obviously definitely encourage them if they're smear positive or have had any pulmonary symptoms, but it's kind of in the avenue of smaller health departments who probably have the resources and aren't overwhelmed. We definitely encourage it, especially because they don't see a lot of TB. So we really want to make sure those contacts are captured. But in general, I think most of the health departments do test. They do investigate most pleural cases.
Okay. Okay. Yeah, because New Jersey used to, but we stopped unless there is a pulmonary involvement as well. Okay. So CDC guidelines recommend that all potential settings for transmission should be visited within 5 business days of initiating the contact investigation or upon identification of setting. We feel as if transmission should not be regarded as an isolated incident confined to a limited area, such as the household. We think transmission is an event that can simultaneously occur in various sites, such as household, social, recreational, workplace, and school. By the way, I think it's important to go back a minute and just mention that just because we initiate an on-site assessment of potential exposure environment, it doesn't mean testing. It doesn't equate to testing. We're just doing the on-site investigation to collect information to determine whether testing is warranted. So I think here, what we do here, this is pre-COVID, we average in this clinic 18 to 21 large-scale investigations a year. And I would say probably 90% of the time, maybe 95% of the time, I do recommend testing, but there are instances where I do not recommend testing based on certain criteria. You know, the environment that the person worked or attended school in, or the level of infectiousness in this case was low. So different things I look at, but it doesn't mean automatically that testing should take place if you do an on-site assessment. I think many people think that just because you go, you're going to test. It may be true primarily in many cases, but some cases it's not. Okay. So these are some of the settings of interest by age group during the infectious period. These are some of the questions we want to ask patients when it comes to congregate settings or potential congregate settings. So for adolescents, we want to ask them, tell us where you worship during the infectious period, tell us where you've traveled, what doctor visits you've made, hospital visits, ED or inpatient, tell me where you work, tell us what school you attend. And for some adolescents, juvenile detention centers. And these are just some of the questions we ask. For adults, it's all the same, but we add in shelters and prisons and drug treatment centers that they may have been in during the infectious period. And for the elderly, the same as well, but we add in shelters, prisons, and long-term care. So, and what I've learned is that, and I'm sure we've all learned, is that unless we ask the patient questions, we're not going to get the answers we want. We can't assume or presume anything. We have to ask, and then we can collect the proper information. And we don't want to be accused of not asking the right questions, and we find out later on that there was potential exposure in a school setting or a work setting or a nursing home. So we're going to discuss now the interaction with the index case. Some of the things I'm going to mention are going to be controversial, I think, but the patient is informed of the need to conduct a large-scale setting investigation. We explained the necessity of the investigation. We explained the purpose of the meeting with site management. Now, revealing the index case identity, dependent upon individual program standards of practice, we do request the index case to sign a consent form authorizing disclosure of confidential information such as the patient's identity and diagnosis to site management, and that will be only shared on a need-to-know basis. If the index case refuses to consent to disclosure, the TB program must either comply or breach confidentiality if refusal threatens the health of the public. And I think when I was in Michigan for our 3 or 4 day course about maybe 2 years ago, I think we had a conversation about this. And maybe just refresh my memory, do you ask for patients' permission, written permission to reveal their identity if it's a school, workplace, or large-scale setting, or do you not do that and simply go in and protect the patient's identity and make a decision based on what the patient tells you about who to test? So I was just kind of curious about that, or Helen or Shawna.
Yeah, this is Shauna. I don't know if maybe Peter knows more concretely, but I actually, I knew you were going to ask us this, and I was like, I actually don't know if we have a set state standard. I think it might vary by local health jurisdiction, what they do. I know in general, it's always good to get the patient on board. So if someone were to ask me, I would say, you know, absolutely, if you're able to get that. But I do know in general, if we feel that a name needs to be disclosed in order to get the information that we need to do, we will do that regardless. But as always, we would always recommend trying to protect the patient's identity as much as possible. But yes, there are some circumstances where it's really not possible to do it without revealing that, at least to, you know, 1 or 2 individuals on a work site. But I think whether or not they actually get direct patient consent depends on local health department. So if anyone's on the call and they're not sure, shoot over an email to me, Helen, or Peter, and we can talk further about what might be required by your local health department.
Okay, thank you. So I can tell you real quickly, and I might have mentioned this when I was in Michigan, but I guess maybe it was at least 10 years ago, we had an investigation. A state worker was investigating a potential exposure at a hair salon. The index case was a stylist, and she was hospitalized. And the state worker called, made an appointment, kept it vague on the phone, but why he was going there, and we'll talk about that in a minute. And the state worker visited the hair salon, and that's when he walked in, there was customers in the hair salon. And the manager or the owner walked forward and said, basically, I think I know why you're here, but why are you here specifically? And unfortunately, in front of all the customers and the hairstylist, the state worker said, yes, I'm here to talk about so-and-so who's diagnosed with TB in the hospital. And so you can see that was just, unfortunately, an incorrect thing to do. And so what happened as a result of that, the patient found out from coworkers, and this patient sued the state health department for breaking confidentiality. And so there was, as you can imagine, lots of meetings with attorneys and all kinds of things going on for quite some time. And I'm not sure what happened, but what I do know eventually what happened is that the lawsuit was dropped, but our state attorney said, you guys better have some kind of a form where the patient can actually give you written consent or not consent to reveal his or her identity. So out of that lawsuit that was dropped, the state health department developed forms for a patient to sign and forms for management to sign that if the patient gives consent, that management will protect the patient's right to medical privacy and only reveal the information on a need-to-know basis. So out of that lawsuit, we developed these forms, and I use them. It's like standard. Wherever I go, I bring them with me, and I make sure the patient signs it before I go to the meeting. And so, yeah, I agree. I cannot envision doing a quality investigation at a school, workplace, shelter, nursing home, whatever, hospital, without disclosing the patient's name, because, you know, obviously we need the help of management to help us figure this out, really who was a close contact, who was not. The patient can tell us so much, but management maybe can tell us more. And so I really think, and if you look at the MMWR from 2005, CDC does endorse this concept of if you're going to reveal a patient's identity, have forms, disclose, you know, the consent forms to protect you and the patient. So we're really glad to see that, because I do know for many years, even in New Jersey, it was taboo. You don't reveal the patient's identity. And I just realized a long time ago, how can I do an investigation without not doing that? I'm not going to recommend testing 500 people to protect the patient when only maybe 50 have to be tested. So anyway, so over time, this is what we're at in New Jersey. We do have these forms, and other states do use them, similar forms, and I think it's the best thing to do to protect the patient and the public health. Okay, so so moving from the patient now to contacting site management notification. We like to contact the highest ranking manager or administrator. We believe notification should be ideally occur 1 to 2 business days after the healthcare worker informed by the patient of a congregate setting exposure. Now, the method notification, we believe telephone notification is preferred method to notifying management and schedule an appointment for face-to-face meeting. We believe mail is too slow, impersonal, unreliable. We discourage unscheduled visits or emails. We think they're inappropriate. And we also believe that over the phone, providing a patient's identity and diagnosis is a risk of violating medical privacy. So telephone is an inappropriate means to provide necessary TB education. So here, I have the luxury of saying, when I call management, I have the luxury of saying, hi, I'm calling from the New Jersey Medical School at Rutgers University. I don't have to say TB at all in my introduction. When I was assigned to other clinics, I would simply say, I'm calling from the local health department. I feel, this is my personal opinion, and other programs do this, I feel to say the word TB over the phone, the red flags go up automatically, who's ever listening, and I think it's risky to mention TB over the phone initially. When you meet face to face, that's a whole different story. But I guess the question to ask your group is, whoever makes these calls, I mean, I have to say there's no right and wrong way of doing these things. So whoever makes these calls, do you say that you're from the state TB program or the local TB program or from the health department? My experience is that even though I keep it vague when I introduce myself on the phone, no matter how many questions I'm asked, well, what's this about? Be more specific. I need to know before I can have you come here. I say, I will speak to you in person in more detail, but over the phone, I do not reveal relevant information about this employee or student. So I'm wondering how Michigan handles that.
Yeah, that's a great one for anyone in the audience if you want to chime in, because at the seat we're not making those calls usually, so it would have. Yeah, I'd love to hear what local health departments do.
I guess people can type it in chat, and Olivia can tell me what the chat is. Because, it's really important that, it's like, I think the next slide, actually, let's go to that slide real quick, because people are thinking. The initial phone call allows for the opportunity to begin the process of building trust and rapport with management. We talk a lot about building trust and rapport with patients, but in these large-scale investigations, we need to, from the very start, that very first phone call, we need to, in a very brief period of time on the phone, we must project a sense of professionalism, sensitivity, and expertise. And we can't be pressured into revealing information over the phone that we don't want to reveal. So we can move on if no one has a comment, but I just think that's important how we present ourselves on the telephone. On the telephone, we know it's a barrier for good communication. And that's why I think that, my personal opinion is that if a program decides to mention, oh, I'm calling about a TB patient, talking about an employee of yours or a student of yours that has TB, well, the telephone's an inappropriate place to even provide good TB education, number one, in my opinion. Number two, you can be assured that once the phone's hung up, that person is going to tell 10 people, and those 10 people will tell 20 more people. And by the time you go to the site, you're doing damage control instead of TB control because everyone's panicking. So I think our experience here is that this type of information should be revealed face-to-face. That's just our opinion here. And again, there's no right and wrong way, just that there's prudent ways of doing it. So during the meeting with management, and by the way, I guess it's a good place to kind of take a pause and say, well, during the public health crisis of coronavirus, a lot of things that we do in TB is sort of like on pause. And I know for us, and probably everybody, these face-to-face meetings may not occur. We have Zoom meetings with management. And when it comes to doing a site visit, you know, we kind of, oddly enough, during, I guess, I took a look at from a year ago, from April until I think it was September, October, I took a look to see how many cases were reported in 2019 versus how many reported during COVID. And it was like a 50% decrease this year. And I was told that across the country, you know, TB patients, you know, were hiding. And maybe Michigan saw the same, I'm not sure, but we did a webinar with a couple of states. I asked that question. I said, where are all the TB patients? Where are they? And so people were afraid to come out. We know that in the summertime and late spring, they were afraid of COVID. They were afraid to go to the hospital. They didn't want to get COVID, even though maybe they felt sick. So during COVID, you know, because we had less patients reported here, I had less investigations to do. So I didn't have to do that many site visits. I only did a couple actually since April. But I did several Zoom meetings with management. And I'm wondering, in Michigan, did you see the same impact of COVID on your investigations? I know here we also curtailed field visits by the field staff. We do a lot of the MOCA, you know, video DOTs now. We curtail field visits and only do it on a case-by-case basis. But I'm kind of wondering, in Michigan, in the local health departments, what have you been doing in terms of these investigations? Of course, again, because of COVID, we haven't had any school investigations because the schools around here are closed, basically. College investigation, we've had none. Had a few work investigations since the summer. But so maybe tell me about Michigan, if you can, about how COVID has impacted your regular TB interviews and your large-scale investigations. Has it had a negative impact on you as well?
Hey, Mark, there's also a question. This is Peter Davidson. Hey, thanks for coming in again. So there's also a question in chat that I don't know the first name, P. Bennett posted. It's actually kind of related to the topic right now.
Yeah, Mark, the question is how is this different from contact tracing for COVID? And it says when we call a management or HR regarding an employee who's COVID positive.
Well, you know, I did contact tracing for the state health department in the beginning, back in well, April, May, and June. I'm not doing it anymore. I never called I never had the opportunity presented to me to call a workplace about a COVID exposure. I only called, you know, we went to the database and we were just given the confirmed case's name and there was like contacts listed and we would just call the contact. So I didn't have any experience in that, but I would think that there's parallels to how you handle the phone call in terms of not revealing too much information. So I guess I'm not sure exactly how to answer the question. Is it that you're looking for a patient that works there or you can't get in touch with the patient at home, so you call the workplace? Is that what the question is? Do we know?
No, not sure, but if anyone would like to expand or unmute yourself to ask as well, please feel free to do so.
Yeah, I guess I would think, while you're thinking about that, I guess I would think that if you're calling the workplace because you can't find the patient at home, I would say it's handled the same way. You have important health matter. That's what I say. We have a very important health matter to discuss. And I think that, you know, for COVID, you might want to say, it's an important health matter. Could you please put me in touch with so-and-so so I can talk privately with this person? That's how I would handle it if I had to call the workplace about finding a COVID contact. Does that answer the question?
Actually, I'm the one that posed the question. What my question was, you were saying that you go in person to speak with management to discuss the positive TB person and don't do it over the phone. However, with COVID, when you're doing contact tracing and an employee works in, let's say, a large manufacturing factory, and this person has tested positive for COVID, you have to notify the employer to get names of close contacts and let them be aware that they had a COVID-19 positive individual within their facility, and you give that individual's name. So how would that differ, legally speaking, between identifying a TB positive individual who potentially has exposed hundreds of people versus a COVID-19 positive individual who has exposed hundreds of people?
Okay, so good question. Yeah, good question. I don't really have a good answer for you. I'm sorry, I apologize. But I would think the parallel is that, I mean, I'm not really sure how it goes because again, my only experience in COVID is calling contacts on the phone, not calling workplaces. But I would think that, I'm not sure statewide, not just in Michigan, but even New Jersey, I'm not sure if confirmed COVID patients sign a release form saying you can call my school or workplace. I'm not really sure. I think that's a very good question. I'm not really sure. I think that the way again, my experience in COVID is that, you know, the confirmed cases I've interviewed, they've just named household contacts, some social contacts, and some work contacts, and they would give me names and phone numbers, and I would call them individually. I did not go to the workplace. It may not be the right answer for you, but that's my own experience. And I think that's something that needs to be discussed at the state level. And what do you do? Do you actually call the employer? I don't think all the several months I did this and worked with several people at the CDC level and the state level, this question never came up because I think we just contacted individual people rather than workplaces. But that's something that I think you should discuss at a much higher level in Michigan as to what to do.
Yeah, this is Shauna. I can chime in a little bit. I haven't personally called workplaces, but I'm on the team that's involved in that. Sorry, my voice is going. So I know that is happening to help facilitate gathering contacts. So that way cases don't have to list every single person. That way we can be sure we're getting the right shifts. And I think some of that's been waived a little bit for COVID. So that way it is kind of, I don't want to say it's okay, but it's become standard practice that it's acceptable to call a workplace, especially for local health departments that do have that capacity. I would say the big difference with TB is because the infectious period is potentially so much longer, it's a longer investigation, we have fewer of them. The initial call to get information would be a little different. I mean, you'd start at the same, you'd say, can I speak to, manager or someone? Hopefully you've gotten the name of the manager from the case if you've talked to them. And then say if important health matter, be careful what you disclose over the phone. And that's where it'd be different from TB. TB, we would still want you to go in person. COVID, I don't think we're doing on-site investigations. But for TB, it's a little bit different. We do want to assess what type of work environment it is. Are there certain people they spent more time around than others? And you might have to start gathering more lists so you can start working backwards. You're not going to go in and just test everyone in the facility. That's also the difference with COVID. COVID, we're not going out and testing contacts. We're referring them to isolate, quarantine, and then get tested. So that's another reason to go on site for TB is because it's going to be a little bit more involved on you guys than it would be for COVID. But as far as the legality of being able to call the workplace, that would all be the same for COVID versus TB. But for TB, because you're going to be going on site probably, you don't need to reveal quite as much over the phone as you would for COVID, because that's kind of a one and done conversation for COVID investigations.
Okay,
yeah,
thank you.
I would agree with that. This is Peter. The only thing I would add is the very few number of times when I have actually gone on site as part of, sort of an assessment to help determine the likelihood of exposure or transmission in a workplace. The other big difference, and Shauna mentioned this, but I think the actual, the physical sort of exploration and directly looking at if it's a work site or a school or, like Mark said, a storefront place, but you don't really know what the space looks like inside until you're physically in it. That's something that we really need to do for TB. And just because of the nature of how the COVID-19 response works, we're just not doing that. It's all sort of like name-based. So I think that's kind of the difference and it gets back to Mark's original point where if there's a risk of exposure in any setting that's not a household, you need to like go to that space and sort of look at it and see what it really looks like and get a sense of how people moved and where they would have interacted.
Well, thank you. I like all those responses, and I guess, yeah, so TB's, just to sum up, TB is typically spread by prolonged intense exposure, and we look at, we discussed last week, we'll do it again, what was the environment, how much exposure was there, but COVID, as we know, it's a 10 to 15 minutes exposure and you're in contact, and then regardless of the environment. So it is different, but I like your responses. You responded, you have more experience than me actually in this. So I appreciate that very much. Any other questions about the initial phone call or contacting management? We're still on management slides. So let me see where we're at.
There's
yeah.
a comment from Erica in the chat field also.
Okay.
Yeah, and Mark, that says that they were told that due to COVID being a pandemic and the emergency orders in place, that waives HIPAA.
Could you repeat that? I haven't heard that.
Yeah, it's just a comment that says that they were told that due to COVID being a pandemic with the emergency orders in place, that HIPAA is waived.
HIPAA is waived in terms of revealing someone's identity? Is that what it means? Or for TB, is that what it means?
Yeah, I think that's what, this is Sean, I think that's what she was getting at. I think actually that's maybe oversimplifying a little bit. It's not that HIPAA is waived, it's that because of our public health code, you are allowed to act and reveal what you need to do in order to perform your public health investigation. So it's not that we're waiving HIPAA, it's that public health is exempt from HIPAA in what they need to do to perform their public health duties. But
okay.
We still want to try to adhere and keep the patient's information as confidential as possible. But for COVID, it is allowed to say it over the phone if it's needed to perform that public health investigation.
Yeah, and that's a Michigan specific.
Yeah, so it's not waiving HIPAA, it's the public health code allows that practice aside from HIPAA.
Okay, and so following up that, does your state use these consent forms to protect the patient's right to medical privacy so there's no lawsuit?
I don't think
that's a good question for the local health departments. We at the state level don't require that. So if anyone from the local health would like to chime in.
Yeah, I would think that
they're saying in the chat, Erica says that they do for TB, but not for COVID.
Okay. All right, so we can take a look at an agenda that
Mark, this is Helen. Could we pause for a second and kind of we've talked about a lot of stuff in the last 40 minutes, just kind of pause and let, if anyone from the local health wants to ask any more questions about, talking about TB over the phone versus going in. I think you asked a really good question about if their TB contact investigations were changed in terms of COVID. Does anyone have anything to add as far as the way they've changed their TB contact investigations recently, if they've had to do it more over the phone or if they've been going in person? Okay. Yeah, thank you. Thanks for pausing. No one has anything else, I guess, so please continue.
Okay, so I'll say something about that since we paused. We have changed our daily operations here. I already mentioned that we really curtailed our daily field visits. We do more contacting of patients over the telephone and FaceTiming. When it comes to TB interviews in a hospital, we don't go to the hospital. Well, hospitals here have lightened up some of their restrictions in terms of visitors, but we're still doing FaceTime interviews or telephone interviews of patients in the hospital, which no one really supports that, but in these times we really need to do that. So that's how we have changed our daily operations. Field visits curtailed, No one's really, we have one patient who's MDR that we do face-to-face DOT, but everyone else is on IMOCA video DOT. No routine field visits, but occasionally there will be one. We had a public health rep who had to go out and give a patient 3 cans to collect sputums, so that was a rarity. And of course, TB interviews they are not done routinely now in the hospital, which is a shame, but we have to protect our staff. So FaceTime has been helpful, telephone interviews. That's how it's impacted our program. Okay. So looking at an agenda for the initial management meeting, I think it's important that we come prepared. We talk about the purpose of the meeting. We discuss confidentiality issues. That's when I take out that's when I tell management, well, we got written consent from the patient to reveal his or her identity. I want you to look at this form. Once you sign the form, then I can reveal the patient identity to you once you sign the form. We talk about potential media interest. We provide some basic TB education to management. We certainly conduct a site tour, whatever the site is, school, workplace, shelter, hospital, healthcare setting. We do talk about, in non-medical terms, the basis of the diagnosis, the current medical status of the patient. Most of the time when I do these investigations, the patient's still hospitalized. We talk about the level of infectiousness prior to diagnosis. We talk about the infectious period and its role in contact identification. We discussed outpatient use of DOT to help ensure adherence to treatment once the patient is cleared to return to that setting. And this is something that not all states can do, but we talk about, if applicable, the legal ramifications of index case and contact non-adherence that is program specific. So we discussed last week that in New Jersey, no contact, once identified and located, can refuse to be tested initially or post-exposure. They can't refuse an x-ray if they're positive on the first test. They can refuse latent treatment, of course, and no index case can refuse outpatient care, whether it's DOT, which is our standard of care, and if they start missing appointments to see a doctor, then miss sputum or x-ray appointments, we can take legal action against them. So I tell this all to management so they know that no one can return here to the site and just do what they want. They have to follow medical instructions. If they don't, New Jersey has the luxury of initiating legal action on patients who demonstrate non-adherence. So the obvious question is, Michigan, you know I'm going to ask this question. So do you have state regulations in Michigan that would be applicable here? In other words, when you go to a meeting, can you actually say to management, if your index case becomes non-adherent, or if your contacts refuse to be tested, we can take legal action against them? Does that happen in Michigan at all? It doesn't happen in every state, by the way. I know that.
So Mark, this is Peter. I'll maybe take a quick swing at that. As far as the case, yes, there again in the public health code there is provision for local health departments to exercise public health legal authority, and the term is actually called police powers, which I actually hate that term. Yeah. For a variety of reasons, but that's what's written. But at any rate, so for the case, yes, there are provisions. But you asked about this last time with in the first course for contacts, and I actually sent that question to our legal affairs office, and they actually, the person who is our main go-to had just returned from maternity leave and was catching up, and she had said it might take some time for her to sort of circle back with us. So I've not heard the answer to that, but I did ask, and I was kind of hoping to have an answer for today, but we just haven't received it.
Well, I'm glad you asked, and hopefully you'll get an answer soon. Yeah,
I mean, our health code is really broadly written, and so on one hand, that's good because it gives local health departments here in Michigan a lot of flexibility. But on the other hand, it's sometimes it can. There's a lot of questions as to how far it really goes. And this is a great one. It's not really clear.
Mm-hmm. So we know, thank you, Peter. So we know that nationally, we did a survey several years ago that only 1/3 of the states in the United States do have regulations that mandate contacts to be evaluated. So you're not alone if Michigan doesn't have that. But, you know, I've said before, I might have said it last month, I say it a lot whenever I do these kind of talks. I just can't imagine myself working in a program, a TB program, where I don't have the backing of the legal component. Not just for cases, but for contacts, because let's face it, you know, today's contact is tomorrow's case. So we need to, like, you know, it'd be wonderful if all the states could figure out a way to expand their regulations and include contact non-adherence. No contact should be able to refuse to be tested. We know they can refuse LTBI treatment, but they shouldn't be able to refuse to rule out disease. That's counterproductive to what we do every day here. It'd be good if you get an answer. And what I usually suggest when we do these types of talks is that you know, contact the states that have regulations that mandate contact adherence, and take a look at their regulations, and then develop your own based on, you know, copy and paste type thing. You know, just develop. That's what New Jersey did when CDC asked the states in 1994, I think it was, to take a look at when MDR and the cases were rising, to take a look at their current regulations and revise them. That's what New Jersey did. It took several years, but New Jersey, you know, asked other states to take a look at their regulations, and New Jersey developed or revised their new regulations. When I was working when I was a state worker working in a northern region of New Jersey in a clinic in 1990s, I was using regulations from the 1800s and the early 1900s to get patients to be adherent. And so, but they worked. You know, we got court orders, and that was the existing regulations. But now we have obviously updated regulations. So good luck, Peter. I really hope that you can get an answer, and perhaps Michigan can, and other states can, you know, eventually, you know, mandate contacts to be tested, because you know, in many states, contacts can refuse, and they're out there after being exposed to an infectious patient, and whether recently or remotely, they may develop TB disease. So we're kind of like spinning our wheels, sort of, by not getting the contacts, because they are tomorrow's case. All right, well, thanks. So what I want to do now is to, I'll talk a little bit more about the management meeting. You know, we talk to management, we understand the environment of the Congress setting. We certainly do a site tour. I do have I'm going to show you some things in the next couple of slides of what I do, but I do have a laser measure, and I go around. I'm not an engineer, but I go around measuring rooms and areas. You want to ask about the total number of individuals associated with the setting. You want to explain local health department standards and practice for identifying and testing identified contacts. You want to talk about, well, we can't provide education sessions. We want to talk about initial post-exposure testing. Where's testing going to take place? On-site, off-site? Who'll be administering and reading the TSD or the IGRAs, where testing will take place, and what we'll discuss. We have to make sure they know that typically it's not one test, as you know. There's usually a post-exposure test. So we want to make sure that management understands everything that we need to do. So the site tour itself, we ideally should include accurate, this is my opinion, that's all, accurate and detailed drawings and or photographs with emphasis on room designs, room sizes and square feet, ceiling height, type of ventilation if known, and the proximity of individuals in relation to the next case. As I mentioned, I do walk around with a laser measurer, and I do walk around with a pad, and I sketch out things. This is an example of a restaurant and kitchen area that I did, you know, as I was walking around this particular restaurant. So I sketch it out, and then we come back, we put it on a computer. This is what it looks like. So real quickly, this is the star represents where the index case worked. This is a grill area way back in the kitchen. The very stuffy area, you see the measurements, it's like really small, tight. And the restaurant, see where it says kitchen area, the restaurant was in front of that. The wait staff would come in, and on the shelf, they would put the orders, and then the food would go on the food line. Oh, I do have it a second right here, I'm sorry. The food would go on the food line, and then the food would be made, and then the wait staff would pick it up. So I decided, standing there watching the whole interaction with the foods, with the wait staff and the grillers, I just thought the only people to be tested was back here, because this is a big open area, very airy, very well ventilated here. And so we tested, I think it was 3 or 4 workers in the back. They were all non-US born. They were all positive on TST. This was several years ago. They all had negative films. They all started latent treatment. I just don't know if they finished latent treatment. But that's an example of what we do. It would go from the drawing to this. Here's another example of a daycare center drawing that I may present next month as one of the cases. I'm not really sure, but so this is a daycare center exposure. This is the sketch I drew out as I was walking around, and then we converted it to a computer drawing. Just real briefly, this was an outbreak where the index case was 3+ on smear, a volunteer, and they were, I believe, 30 US born children, all under the age of 4 years of age. We saw a 40% reactor rate, and we saw multiple cases come out of this daycare center. But hopefully next month I can maybe spend some time talking in more detail about this case. And then the final way is to take a photograph with consent of management. This is a coat factory, and the table in the back here, the index case is not there, but this is where she worked. And I believe this table they were putting on zippers, or I forgot what they were putting on the coats here. That was their assignment. And so this was a huge multi-floor coat manufacturing place. And I just recommended this group of people to be tested. I think they definitely worked together every day with the index case, and they shared lunch together also. But I recommended no other people to be tested. So these drawings or photographs allow us to recall the setting for review at a later date. You know, sometimes we do these investigations, as you may know. You walk into a site and they say, oh no, this is not good. I think people should be tested. And sometimes you walk into a site and say, oh, this is really good ventilation, I'm not worried. And sometimes you're not sure. So you can review these pictures or drawings at a later date meaning the next day. And based on information collected during the assessment, we can provide recommendations regarding the identification and testing of high and low risk contacts. So any questions about that? I'm not sure if other places do that. I've been doing this for years as far as drawings and photographs. I don't take that many photographs, but I like the drawings. But I'm not sure if Michigan does that or anyone else that's on the line. But it is a good idea to consider doing because you have documentation of what you saw, and you can sit down with management if you're not sure what to decide about testing. You can discuss with management. They can see the picture and see the measurements and stuff like that. Like I said, I walk around with the laser measure. I measure the ceiling height, the walls, and draw to best of my ability the actual site that I'm doing. And when I go to a high school or college, I'm doing multiple drawings of multiple classrooms. Typically in high schools, the classrooms are the same size, except if it's a computer room or a special science lab. But typically they're all about the same size, 500, 600 square feet typically. And same thing in college actually, except if it's a lecture hall. So current CDC guidelines indicate that in congregate settings,
Mark,
contact should be tested.
this is Helen. I have a question for you. I'm sorry.
Yeah. No, I'm sorry.
So concerning your drawings and your diagrams, they look like, especially the diagrams they're very detailed, and just visiting and doing all the measurements and then making the diagram and everything, it seems like it takes a lot of time. Do you recommend that people do these for every contact investigation that they have, or what types of contact investigations should they really do these detailed drawings for and models?
Well, for me, I just obviously do them in large scale settings. I haven't done them, now that I think about it, I was going to say I haven't done them in hospitals, but actually I have. I've just done this, the measurements of let's say a patient's room, if there was a potential exposure in a room before a patient was diagnosed with TB. But typically I do this all the time, congregate settings, whether it's a restaurant, whether it's a healthcare, a school, and you can imagine at a high school when kids have 7 classes, I do 7 drawings. And I label each drawing as to what class it is and how many kids are in each class, and I try to get it as clear as possible for me to make a decision. But it doesn't really take that much time. For instance, this one on the screen here, it's a restaurant. I did it real fast. I mean, I just drew it out real fast, sketched it out. It probably took no more than 5 minutes to do it. High school and college would be different because of multiple classrooms. Workplace, maybe a little different, because if it's a workplace with different cubicles, you know, with 100 people, that can take a little longer to draw. But I do it as quick as I can because I don't want to take away from the actual, you know, conversations I'm having with management. So I sketch it out as quick as I can, but as thoroughly as I can. I'm not an artist, as you can see, but for me, it's helpful. For me, it's helpful, and it really, you know, it's helpful. One major way is that it just, like I said, if I come back and I say, gee, I'm really not sure whether people need to test it, I can stare at this picture and for a day or two think about it and make a decision. This is nice when you do a talk, right? When you do a webinar, this is nice to show everybody that this is from a drawing to this is what it looked like, and the same with here. This looks nice, right? And the photograph is real time. So for me, it's, you know, I don't do these. Well, actually, I think I do it every time. Every time I do an investigation at a congregate setting, no matter how small it is or how big it is, I do drawings. I sketch them out. So in terms of regular contact investigations, I've never done it in the household. I've just taken notes, but I've never sketched out, you know, a household investigation site. Just thinking it's a typical house, because any, you know, as you know, I believe it's recommended any household contact is automatically a high-risk contact, technically. Does that answer your question, by the way?
It does, yeah. Thanks for the clarification.
Yeah,
I do really appreciate, you know, the small amount of time that you invest in it. If you look clearly at like the kitchen setting, for example, you can, once you look at it, you can clearly see that the wait staff is probably not, you know, as affected as the rest of the people in the kitchen. And so you can feel really good about your decision about testing all the kitchen staff and holding off on the wait staff until you get the kitchen staff results back. So
exactly. Yeah, exactly. I appreciate your comment. And so, you know, CDC recommends, CDC does not recommend routinely testing customers, right? We know that. The only customers that I've recommended perhaps in the past was I'm trying to think, if the index case was an accountant or an attorney and had regular ongoing meetings with a client in a small office, that would be different. But I've done numerous investigations in dry cleaning establishments, laundromats, restaurants. Never once have I recommended customers to be tested, but only people, as you can see on this drawing, only people who really had close exposure. And so the wait staff, I felt as if were just in and out, and it was very airy. They didn't hang out there in this area. These were the people here. These are people here that I was focused on because of the environment, tight, poorly ventilated, even though there were exhaust fans, poorly ventilated, very hot because of these grills and the grill fry, and it was steaming back there. Up here was not a concern to me. And, you know, the thing is, you know, in these investigations, how can I explain this? In these investigations, there's no hard and fast rules, right? You know, CDC doesn't tell us what to do. CDC doesn't give us guidelines, recommendations, standard of practice for how to conduct these. We're on our own. And that's why every state does them differently. Even within states, we do it differently. What I do here in New Jersey, this part of New Jersey, I'm willing to bet the southern state does it different. The southern part does it maybe differently. The northern part may do it a little differently. So there's no right and wrong way. I always say there's a prudent way of doing it. And so the only thing I'm opposed to is really over-testing unnecessarily. It's the only thing I think we should be careful of, because I think, you know, as we talked about the consensus circle model, we're going to get to that in another minute. You know, I think people just feel safer testing large amounts of people because they don't want to be accused of forgetting to test somebody that may be high risk. So that's the only thing I'm not in favor of, is testing unnecessarily. I think we need to, like, you know, do drawings like this, sit down with management and make a decision together who we think needs to be tested, who doesn't need to be tested. And then you have your circle, and then you can always expand it if you want. Right?
Mark, there's a question in the chat as well. Do you have assessment forms you can share when you visit the site?
The state health department has assessment forms. I don't use them routinely. It's kind of, we can share them with you. It's a checklist that just you check off whether it's smear positive, X-ray capillary, coughing, it's all those things, and then you come up with a numerical number. it's an arbitrary number, and if the number is in a certain category, it's considered high risk, and you should go do the workplace or the congregate setting. I personally don't use it. I think it serves its purpose. It was developed actually many years ago for case managers in New Jersey that didn't have experience doing these investigations. So I don't use them. I mean, I'm not above using them. I feel like I personally don't need a checklist to have me make a decision whether I need to go to workplace. I look at the patient's chart, I review what I need to review, smear positive, cavitary disease, cough, or whatever I'm looking for. And to me, that's enough to drive me to the decision to go to do with a congregate setting. But I'll try to remember to share those forms. Maybe Olivia, you can make a note. We can send those forms to you that the state uses that helps decide whether, you know, someone is considered high risk for transmission in a workplace or in a congregate setting. So we can send that to you. Okay. Let's see, where were we now? We did that. I think we're here. The current CDC guidelines do recommend that, or they indicate that in a congregate setting, contact should be characterized as high risk if they've been exposed to a suspected or confirmed pulmonary, laryngeal, or pleural TB case. Again, New Jersey does not do that, but Michigan does, others do, who was diagnosed with a positive smear or cavitary disease. Low-risk contacts should be reserved for possible expansion of the investigation. This goes back to the concentric circle model that CDC says really you shouldn't expand to low risk unless you see transmission in the high risk. Many programs, you know, kind of ignore that, and they test, you know, they throw the net out really far and wide, and they test people, large amounts of people, I think sometimes unnecessarily. And we talked about this before, that sometimes when you do that, you're going to get remote infection from people who were infected years ago. It's not a bad thing to find them, because then you can give them x-rays and get them treatment, prevent disease. But we know the purpose of a contact investigation is to identify recently exposed, recently infected people, because we know that, according to CDC, that those people can break down with disease within 2 years. So we're looking for people who are recently infected, not remotely infected. And the wider you throw that net out, you're going to find remote infection for sure. Okay. Here's the circle. I think actually, yes. So we reviewed this last month in detail. If you'd like me to do it again, I will. But basically, we talked about, you know, the concept is, you know, the inner circle is the close, prolonged contacts, household, close social, co-workers, students, co-students who have, as opposed to COVID, who have prolonged exposure over the period of time in the infectious period. And every circle out represents people with less and less exposure. So the impact of TB transmission is typically found in the immediate vicinity of the index case, while those who spend less time at a greater distance are considered lower risk for TB transmission infection. Those, however, in absence of medical risk factors. For those who have medical risk factors, like I think we talked about someone out here who maybe we may miss in the investigation, who may be immunocompromised or have a medical condition like diabetes, who has limited exposure here and was missed in the investigation, that limited exposure could result in transmission, and that person may be missed. And again, that's why I think many programs, they just throw the net over the whole concentric circle and they test everybody, hoping they're not going to miss someone like this. And I do understand it, I really do, but I just think, you know, we're testing unnecessarily and to find that one person that maybe we might have missed. So the way to get around it is to, in the beginning investigation, is to develop a list of medical risk factors. And when we send out letters to contacts or to employees or to students, parents, we are considering, we haven't done it yet, we're considering including this list of medical risk factors in the letter and saying that if you're a child or if you have any of the following risk factors, please let us know, and then we can make a decision whether testing is warranted for those people who are outside the circle. Whenever I do these education sessions, I'm kind of jumping ahead of myself, but I always like to have a doctor and nurse with me. I think a doctor gives credibility to what I do. And so these kind of questions that come up, I'd rather have a doctor or a nurse handle those questions if it's a medical issue. So any questions about the concentric circle model? It is controversial. It's not fully supported by everybody across the country. Some people love it, some people don't. Even CDC, Some people support it, some people don't. So it is a methodology that just, you know, I think I mentioned last month, it's a methodology that allows for it. It's a secondary tool. It's a visual tool. The investigators do the work. The investigators go to the site, meet with management, do the drawings, collect information, make decisions, who the contact, and you put the contact's names, if you have enough room, or give each contact a number and put it in here, and then all of a sudden you see, well, if I go to a place that has 100 people, let's say it's a workplace, and I identify 20 as high risk, I put the 20 names or whatever I put in here, and then maybe this circle has 10, this circle has 30, whatever it might be, and I start here. And I know if I'm going to expand, here's where they are. They're sitting out here waiting for me. So, but it is controversial, and I do, when I go to a management meeting, I bring a hard copy, a color copy of this with me, and if I sense that management is disagreeing with my decisions about, you know, let's say there's 100 people there, and I say, well, I'm only going to test 20 people. If they are pushing for 80 more, I take out this drawing, and I say, this is what I'm trying to explain to you, and I explain the concept. And my experience is that once management sees this drawing, I could spend an hour talking about how we shouldn't test people, but when they see this drawing, it's like magical. They get it. And so I like this drawing. I like this model. Even though it's imperfect, it has helped me many times in large-scale investigations. So if you'd like to talk more about it, we can.
And Mark, there's a question in the chat as well.
Yeah.
Do you have advice for limiting the number of contacts identified for testing in a scenario when exposure to the index case took place 12+ months prior to the case investigation?
Well, CDC recommends not going back more than a year for any of these contact investigations. So the further you go back, the more difficult it becomes to identify contacts. But if for whatever reason, if you think it's a legitimate infectious period that goes back 12 or 13 months, you know, I guess it's, you know, not impossible if someone's coughing for 3, 4, 5, 6 months, and you go back 3 months before that, then you're at a year already almost. So I guess if I understand the question, if it's a legitimate contact with legitimate exposure during that infectious period, they should be tested. Was that the question, you think?
Yeah.
Or was that an appropriate answer, I should say?
Yeah, and Mr. Sean, I just wanted to add on, and you still follow this concentric circle method, no matter how long ago it was. You know, even if it was 12 months, you still add them to your list. If you determine that they're that higher risk contact, then yeah, we definitely want to test them. But we don't go backwards based on time frame, we go backwards based on exposure level. So if it was 12 months ago and they had very casual contacts, then they're still going to be in that lower risk group and only tested if we're finding a lot of positive contacts that were closer to the case. Yeah,
I agree with that. Yeah, absolutely. Now, if it's someone who you find who is from a year ago, what had really close exposure, you're going to put them in the middle circle, in the first circle, correct?
Yep, and we've done that before. We found, hey, they lived with this person 5 months ago. They don't live with them now. We say that's a household contact. They're highest. Right. They're high risk, and we've done it. We've tested them. Yeah, good. I agree with that philosophy. Yeah. Okay, so we discussed this last month. I think it's worth discussing it again. The transmission probability assessment, person, place, time, and contact characteristics. Just to summarize, the person characteristics refers to the index case. What is about this patient that we think maybe transmission is occurring? We look at the bacteriology or pathology results. Is it 4+ on sputum smear or 1+? Is it less than 1? What's the radiology results? Is there cavitary disease or not? We know in a cavity there could be millions of TB organisms just sitting there. We look at the symptom history, primarily cough. We know that TB is not spread by weight loss or night sweats. So we're looking, is that patient coughing? Now, a patient could be smear negative and cough, and we're still concerned, right? We're not going to disregard that, even with no cavity. So then we're looking at the place, the exposure. This is all during the environment of exposure during the infectious period to this patient. What was the environment? Was it indoors, outdoors? Was it in a small, poorly ventilated classroom, crowded classroom? Or was it a big lecture hall with plenty of ventilation and students were sitting far apart?
Was it in the workplace where a few people shared a small office of 600 square feet with 3 or 4 cubicles? Or was it in a huge workplace where there was 100 cubicles? What was the ceiling height? What was the ventilation during the infectious period? And we're looking at the time. Time we refer to the duration and frequency of exposure during the infectious period. In this place with this person, was it just casual? Was it like COVID, 15 minutes occasionally? Or was it an hour a day or several hours a week? Or you know, and we know TB is, as I said earlier, is typically spread by prolonged exposure. So during the infectious period, was there multiple hours of exposure per day, per week, per month during the infectious period? Again, in this place with this person. And then we look at the contacts. Who are the contacts? Are they infants, children, immunocompromised, immunocompetent? Are they drug users, alcohol abusers? What's the medical risk factors? Are they diabetic? So we look at all this, and we make a decision based on these 4 characteristics of these four individuals, of these four characteristics. I'm sorry, let me go back. 4 characteristics of whether someone needs to be tested. And that's really what it comes down to: person, place, time, and contact characteristics during the infectious period. Okay, so moving on to notification and testing of high-risk contacts, we should give priority and notify all high-risk contacts and others associated with the congregate setting regarding potential exposure. So most places, most states, I'm sure probably all, they send out letters. If it's a school, a workplace, whatever it might be, a notification letter. Here in New Jersey, we send out to those that we identified as needing to be tested, and the information letter goes to everybody else, the worried well, the low risk contacts. So for instance, if I go to a school, there's 2,000 students in the school, and I identify 100 students and faculty to be tested, they will get the notification letter. And then 1,900 people would get the information letter. And everyone is, and in this letter, we talk about the time, date, and location of testing for all contacts. We also talk about how quickly these testings should take place. CDC recommends 7 to 17 business days, depending on the case, smear, and X-ray results. We like to get done as quickly as possible, of course, as all states recommend. But the education sessions we feel that's also included in the letter, providing education sessions for everybody, not just the contacts that to be tested, but for everybody that in the congregate setting. And in schools, as you know, because I know Michigan does this, you can have an evening session with parents and children. You can have a session after school with faculty. All of us feel that the education sessions are a critical component of these investigations. They're a captured audience. They need information. We're going to give them information. They're not going to get it from the newspapers. They're going to get it from us. They're going to get the facts from us, how TB is spread, how it's not spread, who's a high-risk contact, who's not. We believe that these sessions really inform people about TB exposure, transmission, and treatment. We believe that these sessions held prior to testing has been documented to help reduce anxiety for those identified as contacts in addition to word well. So we did a survey here several years ago, and it was an MPH student that was looking for a project, and she knew I went out to do these investigations, and we thought, well, gee, let's see, if our message is being accepted. So we developed a standardized slide set for these information sessions. And we enrolled about 400 or 500 people in these sessions. Every time we went to do an education session, whether it was in the evening or daytime, with parents, whoever it might have been, when they walked in, we asked them to volunteer. We gave them a questionnaire, about 15 questions, multiple choice, true, false, no trick questions. Just we wanted to assess their knowledge of TB, their worry level, and their level of anxiety about this exposure. They would answer the questions. We would collect it. The names weren't on it. We give them a number. We collect it, then I would do the slide set, and then we give them the questionnaire again. And what we found is exactly what we wanted to find, is that as a result of the education sessions, people felt less worried, less anxious, and more educated and informed about TB. So we felt very good about that. So these sessions, as you all know, are really critical in these investigations. So during these sessions, during the session with management, it's a small group. We talk about how TB is not transmitted. We talk about what factors influence transmission. We talk about things like the difference between TB infection, TB disease, and we talk about treatment for infection disease and the importance of adherence, and we talk about DOT as well. We talk about lots of things during the management meeting, but these are some of the things that we discuss, of course. For the education sessions for the general public of the congregate setting, we provide the same information. We do have a prepared slide set or standard slide set. We don't show the slide set to management, but I do bring a hard copy with me, and I just go through the slides, my hard copy, just so I don't forget to bring up anything. So for the high risk and low risk and worried well meeting, we provide the same information, but we do a slide set. We have the slides. Well, we used to use overheads. I should get rid of that overhead. We used to use overheads. Now we use, of course, PowerPoint slides. And we hand out printed education material as well. And this slide also was from last month, but I thought it was worth repeating. Consideration of the following factors are recommended for expanding investigation. CDC recommends that we should achieve program objectives with high-risk contacts first before we expand. And if you go back to this last sub-bullet here, in absence of recent transmission, investigation should not be expanded. So, however, we can expand if we have an unexpected high rate of positive TSDs or IGRAs, or evidence of secondary cases, or transmission to children less than 5 years of age, or any child actually, documented TSD, IGRA conversions, or a change in TST. It's supposed to be TST status from negative to positive, not IGRA. Again, thinking of the consensus circle model, we start small. We expand if we need to expand. But in the absence of recent transmission, we technically should not be expanding. Again, this was discussed, I believe, last month, but I left it in depending on the settings. These are some of the problems and challenges of congregate settings. Some of the problems and challenges could be potential for a large number of contacts, potential for vague information for determining contact priorities. The example I use typically, I might have used it last month, I apologize if it's redundant, but go to a shoe factory and the patient tells us his or her assignment is on a particular like conveyor belt, and my assignment is to put heels on shoes. When we meet with management, we find out that the patient actually rotates to different assignments, and maybe once or twice a week puts heels on shoes, and other days on a different assembly line putting laces on shoes. So sometimes it's really hard to figure out the contact priorities. And by the way, I have to be fair and honest. Sometimes the consensus circle model does not fit. You know, it's nice when it fits. It's nice when it works. But sometimes you do find yourself testing more than you want to test when you can't figure out really who is a high priority or high risk and who's not. I've had that experience. Potential for incomplete identity and locating information, that's not unusual. Challenges in maintaining patient confidentiality. Media coverage is one that can be a problem. We welcome media coverage, but it can be a problem if they try to if they attempt to break patient confidentiality, which happened to us several years ago. And collaboration with officials who are unfamiliar with TB, that it can be a problem if they think that they could be successful in their. I'm thinking of the meatpacking company that I went to, and the president of the meatpacking company was trying to tell me who should be tested. And I very politely and professionally took out my consensus circle model hard copy, and I explained that you're successful in meatpacking and we're successful in TB control. And so he listened to me, and we only tested a small group of people. Closure investigation is consistent with local health department standards of practice for closing an investigation that's dependent upon completion of initial and post-exposure testing, medical evaluations, and treatment, if appropriate, of all identified contacts. Years ago, in the 1970s and 80s, a contact investigation, believe it or not, was closed when you identified contacts and they got tested. There was no follow-up of really completion of therapy, and that's something that obviously has changed over the last decade. And so I came across, this is the last slide, I came across this statement. I was doing outside reading a couple years ago. No matter how hard the winds howl, don't panic, take things one step at a time. I thought it was pretty applicable to what we do in TB control, because we know in TB control, when we do these large-scale investigations, there's typically some background noise that comes from parents, politicians, and the media that really want more people tested than what we're recommending. And I think what we need to present ourselves as the experts in TB, and we need to follow the step-by-step process in TB control. We shouldn't panic nor bow to the pressure of this background noise. So, I'd like to maybe take some questions if there's any more questions, or have a discussion about any of the slides, anything you'd like to go over. I'd be happy to do that with you.